a nice mix of green space and urban life. And fortunately, there are fewer moose there than you might be worried about in Canada. This is the University of Toronto here, where I was did pretty much all of my training, except for a brief year in Boston, where I did my pediatrics fellowship. But now I'm back here. This is where I'm from. And I say that almost literally because I was born over here. I had my first job that wasn't in a farm or a warehouse as a janitor in this hospital here. And now I'm at SickKids, which is a small but standalone pediatric hospital. It has about 273 beds, and we do about 12,000 surgeries per year. These are my partners. You may recognize some of the people, and I feel very, very fortunate to work with them. We feel very fortunate to work with people of Toronto. For context, we have about 2.9 million people in the city proper and around 6 million in the Greater Toronto area. And that may not be a big city for where many of you are from, but it is the biggest city in Canada. We are in the province of Ontario, which is the second largest province by size and largest province by population. And to serve our population, we have 4 tertiary pediatric hospitals, but really only one quaternary care center at SickKids. And so we try and focus our care on patients of certain medical and surgical complexities to try and use our limited resources wisely. So before I go on, just a word on mastery. As a lifelong student of martial arts, I feel always uncomfortable when this term is applied to me. These are some of the masters of our discipline from North America and Japan and Canada who were together in one of my teacher's basements once when I was a young boy. And I think many of them would say that we never achieve mastery. We should always attempt to pursue perfection for the rest of our careers. And I think that when there is something as rare as choanal atresia, we have to be honest about that. And so I will be talking to you about what my experience is and some tips that I've learned over time. But at the end of this, I do want to hear from all of you because I really only think that by sharing our experiences and pooling our knowledge, we can only achieve collective mastery of something as complicated as this condition. And so I'm going to talk today about how we've used an honest approach in this condition as a whole to create new ways to reimagine our approach to the management of this condition. And to do that, I'm going to talk about a case, and I'm going to illustrate this case and go back to it throughout the talk today. It begins in the beginning with a 31-year-old healthy G0P0 mother who underwent a routine anatomical scan, and her baby was found to have some renal anomalies. A follow-up scan then identified ventriculomegaly within the brain, which led to a fetal MRI. This is how they like to look at those fetal MRIs, but we're going to look at this in the more normal otolaryngology way. And what we notice here is there's fluid in the aerodigestive tract, which we would expect. There's fluid in the nose, which we would also expect. But in addition to the ventriculomegaly and the renal anomalies, they had also noted that this indicated that the child had bilateral choanal atresia. When they looked at the ears, they found the semicircular canals were absent, and looking at the olfactory cleft, there were no olfactory grooves. So, knowing this, we decided to proceed with an in utero transnasal endoscopic repair of bilateral choanal atresia. Just kidding. This is a normal talk. This child was born by spontaneous vaginal delivery at 39 plus weeks, and he did terribly because he couldn't breathe. But knowing that this was the case, this was an attended to delivery, and so he was intubated immediately and stabilized with no ill effects. He then underwent his echocardiogram, which showed a range of cardiac anomalies. And I think you're starting to realize a picture is starting to emerge. We have a child with ventriculomegaly, renal problems,
I'm
cardiac
going to
problems.
interrupt you over here. Your voice is slightly breaking, glitching.
Oh,
So just, uh,
is it still
uh,
happening?
yes, it's happening.
Oh, okay.
Um,
I don't know what
it was
to
fine
do.
before you started. Now there's all of a sudden a couple of slides. Uh,
Interesting.
that's
Okay, I can see if my camera has changed. It's still breaking up, is it?
no, it's better now.
Okay. Okay. Hopefully it stays that way.
Okay,
So a picture is
sorry.
starting to
Continue.
emerge here. No, thank you very much, Dr. Nick. And clearly, this child has something going on, and his genetics confirmed the charge. So a complete systemic workup for these children is critical because multisystem anomalies can be found in as many as in about half of them, with about 65% in children with bilateral choanal atresia. And while this is an airway emergency and we feel compelled to operate on them, you want to make sure that at the very least you obtain brain imaging either via ultrasound or MRI and an echocardiogram before they go to the OR, not only to ensure that they do not have any life-limiting conditions, but also be sure that this child will make it through the operation. Now, the timing of surgery is often driven by the ICU and our own desire to extubate these young babies. But that must be weighed in counterbalance to the systemic conditions that they have, their long-term prognosis, and of course their size and their weight. And so, as you can imagine, this is clearly a multidisciplinary condition. But otolaryngology does have an important role at that table, more than just being the ones who can make a whole. We have to remind them of things that the ICU doesn't necessarily always think about. Hearing loss and vestibular dysfunction, which can have significant impacts on their quality of life, facial palsies. And remember that there are other airway anomalies that can be encountered. And of course, even after we repair their nose, there's always the risk of recurrence. And I feel that parents need to know about these things before they make their decisions. The risk of recurrence has been studied, and some of the most common themes that come back to us are young age, low birth weight, charge, and patients with bilateral atresia. And so obviously these things overlaps to some degree. And if we go back to our case, our patient had all four of them. Now, birth weight has been looked at in a number of studies, and even case reports have gone down to 1,200 grams. This is a paper that came out of Necker Children's Hospital in Paris, where they outline how they were able to do this safely and successfully in a very, very small infant. But these patients have a number of important considerations that must be taken into account before you go to the operating room, both perioperatively and intraoperatively. And therefore, it is critical to ensure that your facility can meet those needs should you decide to venture down this path instead of waiting for surgery to be done later. On the whole, surgery can be broken up into two main groups. We have our transpalatal approaches, which have become slightly less common, and our transnasal approaches. I've been a bit broad with my categories here, but transnasal approaches can be done by a puncture dilation or endoscopically, which can be done transnasally, transeptally, sublabally, but all essentially are doing the same thing, and we're using a range of instrumentation to go through the nose. And that's the type of operation we're going to be talking about mostly today. So here's the CT scan of our little charge baby. This is when he was 9 days old, weighing 3.2 kilos. And we felt that at that point he was starting to have some issues with the vent. And so we had decided to go ahead with surgery. You can see that he has a mixed bony membranous atresia bilaterally within the nose. And so when we go to the OR, we have to not only have a plan of attack in terms of our anatomy, but we also have to know what weapons we're going to carry with us. And so when we're going into these little tiny noses, we need to have some ways to get to the back of those little tiny spaces. One of the most common things that we consider is using a smaller endoscope. In pediatric otolaryngology, this is second nature to us. We use a smaller scope to get into a subglottic stenosis or fish a peanut from a distal bronchus. But I would recommend that in the nose, you always try to use the largest scope you can to not compromise visualization and illumination unless you absolutely have to. And I find that my trainees are often surprised by how we can work around a large scope even in a small nose. One of the ways that we do this is by using smaller instruments. The use of otological instrumentation in the nose has become quite commonplace in pediatric rhinology. Here you can see the middle ear scissors being used to create a little nasal septal flap for an infant with a meningocele. And the use of these suction dissection instruments has also been quite helpful. That's come along with the advent of endoscopic ear surgery. Longer scopes is also something that we've found, and actually we found this by accident. I was doing a case in a choanal atresia child, and I'd reached the end of my rope. I'd done every trick I knew. I was using ear instruments, and I still just didn't have enough space to do the maneuvers I did. And I finally broke down and asked for a smaller scope. And my dutiful Airway nurses ran off to get me a smaller scope, but they actually brought me the endoscope for a rigid bronch. And I wanted, it's not exactly what I wanted, but I was frustrated and I just wanted to get ahead with the case. And I said, just give it to me anyway. And so we ended up using that scope. And what I found was that by having one hand sit higher than the other, I was actually able to get my hands just a little closer together. And that extra millimeter gave me the space I needed to finish the case. And although this was as awkward as it looks in this picture, it still remains on my list of things when I'm thinking 3 and 4 steps ahead of where I might be if I'm starting to run into trouble in the nose. So let's go into the nose here, back to our 9-day-old. This is him when we're looking in the nose, and you can see the atretic side there. In infants, I tend to use monopolar cautery to raise my flaps so that I limit the amount of blood loss, but also I don't want to have as much soilage of the scope because it's such a small space from bleeding onto the front of the scope. And so here you can see that an inferiorly based flap being created on the right hand side. Here we're using our endoscopic suction separator initially to finish off that cut on the floor. That's quite important to get the flap right out of the way so you don't get it stuck in your drill. And here we're raising our flap with our ear instruments and anticipating it being a little sticky at the back where the septum meets the atretic plate. We use our endoscopic ear scissors, and then we're going to use our suction dissector curved to the side to take down that flap. On the contralateral side here, I'm going to make a posterior-superiorly based flap, and I usually leave it this way until the end where I decide where I want to put the flap, and then I will finish the cuts at the end. So here you can see that. And then on this side, I had a little bit more room, even in this little baby. So I was able to use a freer elevator to get the flap up, which was a little bit quicker. And then as we get to the back of the nose, remember this was a bony membranous atresia. So as we got to the back here, we were able to see into the nasopharynx as we opened that flap. Now, this is how I do it in children with bilateral choanal atresias, but in unilateral choanal atresias, sometimes I do it a little bit differently. In part, this is because these are older children with more space, and therefore I think that the small amount of bleeding that you get from the um, cold steel technique is less meaningful to the older children. And that way you preserve the edges of your flap a little bit more from any kind of cauterization injury. So this is a 4-year-old who presented with unilateral choanal atresia that we found after actually taking a foreign body out of his nose. And so you can see here he has a bony choanal atresia with a funny little septation in the back of the nose, which I think is actually quite common. Here's the nose. We're looking on the atretic side here. That's looking up at that small septation at the back of the nose there. And then here we're going to raise the flap. I start the anterior part of the cut with the monopolar cautery because I don't want any bleeding to bother the front of my scope and continuously irritate me and dirty the scope. When I have a trainee do these, I usually have them mark out the incision to start because I find that there's a tendency to narrow the flap inferiorly when you do it as this direct line because they go perpendicular to the floor, and that doesn't account for the curvature of the vomer. And so you can have a very narrow base to your flap, which may not give you as much coverage as you otherwise get. So here we're doing our anterior cut, and then I'm going to start raising the flap in a submucopericondyal plane before I've cut the top of the flap. And I do that to provide myself with some tension. It serves to hold the flap down so that I can pierce through the back edge of the flap with my freer. And then here you can see using the middle ear scissors to cut the back edge so that I keep that fresh edge that is a little bit healthier. And then we cut the top edge once we've created those 2 cuts. You can see that this is a Canadian video because the scissors aren't working. We prefer to just mash at tissue until the cells give up and they drop their intercellular junctions rather than to get instruments that actually cut things. Many of you might have experienced something similar. So here we have our flap cut set down. Now, mucosal flaps are not new. These have been described already in the 1970s by Ralph Millard for transpalatal surgeries. And over time, they were gradually adopted to endonasal surgeons doing choanal atresias to help cover bone and limit neo-osteogenesis. This speaks to actually something that I always loved about otolaryngology, is especially as I was picking a specialty, because I noticed that my mentors were always open to new ideas and trying new things and adopting new techniques to see if it could help their patients. And I think we continue to do that today. Now, since these original descriptions, this has been studied quite extensively. And so much so that there's been a systematic review that compiled 9 studies in 266 patients, with that 13% of which had charge, so even including a fairly challenging population of choanal atresia, and they still had an 89% success rate with only 11% of patients requiring revision surgery. That is an exceedingly low revision surgery rate, and so it really speaks to how useful these flaps can be. Once we raise our flap, it's time to address the atretic plate. And so, it being bony membranous, I thought perhaps I might be able to pop through that bone. I couldn't. I tried something a little sharper. I brought in my trusty caudal, my special little instrument, and then eventually we had to drill out the bone. And I mention this basically because you just have to always have all your tools at the ready to get to the back nose. Now, after we got our atretic plate open, I'm going to do a posterior septectomy. This is an adult backbiter in a 9-day-old infant. So I place this on the one side, and then I guide my cuts with the endoscope on the contralateral side, which is a common technique that we use in infants. And once we've created some room, I bring in my 2 mm Kerrison to just start making a little bit more forward movement a little bit more quickly. Here's our posterior septectomy completed in that retrograde fashion, and our flaps being laid down at the end, and I'll usually support those with some tissue. Oops. The posterior septectomy was first described by Stankiewicz in 1990, and you can see in his diagrams here, it's done pretty much the same way now as it was back then. After creating the opening in the atretic plate, a backbiter comes in and takes down the posterior 1 centimeter of the vomer up to the height of the middle turbinate to increase the space medially, to widen the space medially without having to go out laterally into the bone of the palatine bone. And he felt that that would help increase the space there. Sanjay Parikh from Seattle Children's once described this as one of the greatest innovations he's seen in pediatric rhinology, and I have to agree. So I just want to talk about this a little bit more because I think it's worthy of further discussion. So I'm not a good artist and people don't have the heart to tell me, so I keep drawing stuff like this, and my residents have to suffer from it all the time. But you have to imagine that this is a nose. This is the front of the nose. Here's the back where the choana would be, but we're talking about choanal atresia. So this is an atretic plate. And on the sides here, we have our 2 common techniques, our puncture dilation and our posterior septectomy. Now, when I was a resident, I was once told that the hardest thing you can do in surgery is make a circle. But in bilateral choanal atresia, we've been trying to make 2 of them. And I think that when we do a posterior septectomy, we're doing more than Dr. Stankiewicz thought. We're doing more than just widening that opening. I think what we're doing is we're creating a more complex 3-dimensional space that's harder to scar down, that buys children some time to mucosalize those bony edges and gets them a little further in their life before they scar down and restenose. Now, restenosis is a big problem, and we know that it's not just stenosis and restenosis, but it's also re-restenosis. This happens quite frequently. In these 2 studies, they quoted a recurrence rate of around 30 to 40%, and I honestly think that that's being a little bit generous and probably reflects more what we're willing to call a recurrence rather than what truly is happening. In fact, when I talk to patients in the preoperative setting, I often counsel them that restenosis is considered part of the natural history of this condition, and rather than a complication, and a touch-up procedure may be required. The mean time to revision in these studies was 18 months, and as we discussed, they both hinted at these risk factors. Now, this is such a vexing problem that we've tried all sorts of different things to prevent restenosis. One of the most common things that we talk about and we discuss and argue about is the use of stents. This has now been studied quite extensively, so much so that Julie Strakowski, while she was at Boston Children's, was able to do a meta-analysis on this. And what she found when she pooled both individual studies and comparative studies was that there was no statistically significant improvement in stents versus the no stent population. In fact, she also looked at the duration of stenting. So what stent was used, she found that the patients who had shorter durations of stenting had better outcomes than longer durations. And I think perhaps what this speaks to is the use of the stent. I think what we're doing with stenting is getting children through critical periods of airway swelling, but not preventing restenosis. Now, Julie also did something very interesting. She collected all of the different complications that were reported in all of these studies. And what she found was the majority of the complications that were occurring were, in fact, stent related with things like dislodgement, blockage, and so forth. And so while those stents are in, these children need to be monitored so that they don't run into trouble from that alone. Now, not all stents are the same. And in 2017, Bangiev et al. Reported a small series of patients who'd been stented with the drug-eluting stents, and they found in their 3 patients no revision surgeries were required. Subsequent to that, Wang et al. Did a cohort study comparing silicone stents to drug-eluting stents, and they found that the patients with the drug-eluting stents had shorter OR times, shorter lengths of stay, and a reduced number of procedures overall. And this has become quite common to use in many centers. Now, the problem with these stents are, one, they're very expensive, and depending on where you're from in the world, that can be more of a factor than in others. And they're not approved everywhere. In fact, they're not approved in Canada, and so these are not available to us. And so until they are, we have to think about other things. One of the things that's often discussed as well is mitomycin C. Mitomycin C is used commonly in gastroenterology, general surgery, otolaryngology. It's an antibiotic from the Streptomyces species that has anti-neoplastic and anti-proliferative properties, and most importantly, it appears to be able to inhibit fibroblasts. So the idea is that at the time of surgery, mitomycin C is applied topically, and then you kind of hope that it stays there until around 3 days later when the fibroblasts arrive at the wound to inhibit their proliferation. When this was looked at by Julie Strakowski, she actually did not find sufficient information to draw a conclusion. But when the IPOCS consensus group asked their experts, 82% responded that it should never be used, and they ultimately landed on a softer conclusion, suggesting that it just not be used for the first intervention. So I'm going to finish with just one more case here. This is a 26-month-old with Treacher Collins, and I think it brings together a lot of the points that we just talked about. This child received a tracheostomy at birth for respiratory distress. In fact, they were unintubatable and had to get their tracheostomy over a rigid bronchoscope, which is quite uncommon in the modern era. Unfortunately, they had come to us because they were not tolerating capping or speaking valves, and they were not progressing towards decannulation. And so, and this patient had a known bilateral choanal atresia. And so here you can see their preoperative CT scan, and clearly they have the bony atresia, but it's on the sagittal where you can really see just what a big problem this is going to be. This is a fairly typical Treacher-Collins nose where there's a somewhat unusual vomer development that's quite broad and wide, and it's connecting the hard palate to the clivus. I had to use the word clivus because this is a skull-based masterclass, so I just wanted to bring that in there. So, and I'm just going to bring this to your attention once more. Looking at the sagittal on the left and the right, we have our bony structure here with our unusual Volmerian structure that's connecting the hard palate to the sphenoid base. And that creates a big problem for us. Now, one of the things that when we looked at this child what we noticed was they had a couple of things going for them. One was the position of their uvula. Their uvula was anterior. Sometimes in a Treacher-Collins, the uvula is coming off of the posterior oropharyngeal wall. So this meant that this patient had a rudimentary mucosalized nasal pharynx for us. One of the issues though that we were thinking about though was we sure could drill this out. We could drill this bone out quite easily. And that would give us a good amount of space, although it really only bought us 4 millimeters to 5 millimeters on the CT scan. And you're going to see intraoperatively that it was actually much less than that. And in such a long, raw space, we really worried about osteogenesis closing this area up completely. And so although we can get a nice open three-dimensional structure here, we weren't sure if in this child it would be sufficient to stay open or get them decannulated. And as I mentioned, there were a couple of features that were working for this child. And in this case was this 2-year-old child had already developed a sphenoid sinus, and it was nicely aerated on the left-hand side. And so we were wondering, could we make use of this sphenoid sinus to drill out the inferior portion of the sphenoid and have a mucosally lined surface there for us to serve as their neopharynx. So that's what we decided to do. So here you can see this patient intraoperatively. Although there are two, I still decided to use the monopolar to raise my flaps. I did an inferiorly based flap on this side, and then I'm going to use my ear instruments to raise that flap up. This was it wasn't a particularly challenging flap, but knowing the amount of bone that we were going to deal with, I went directly to the drill. And so here we're just starting to drill through that thick bone of that unusual vomer. And then here we start to notice that we get into we found some soft tissue. What I wasn't sure of at this stage was, were we dealing with the soft palate, or had I come into that space of that rudimentary nasopharynx and I was pulling that mucosa down, which would ultimately get me behind the adenoid tissue. So to create some more room, I switched to a kerrison. This is a 1 mm kerrison, given how small the nose was, just to create a little bit more room here to try and identify what we were doing. We brought in the image-guided suction here and still couldn't tell. I tried to pass a 6 French suction catheter to get it into the mouth, and it didn't pass, so I assumed I had to raise this mucosa, so I used my caudal to create an incision, and now we can see into the nasopharynx, and that allowed us to proceed with a little bit more confidence through this bone in this area here. And so as we start to go, we're going to widen this and get a bit of a better sense of where we are. And we really wanted to create some room here for bleeding and increased visualization. We're now going to do our posterior septectomy, as opposed to that previous case that I showed you. In this case, I decided to do an anterograde posterior septectomy, similar to the way we would do it for creating a septal window for a transsphenoidal case. Pardon me. Sorry. That time it wasn't the microphone that was cutting out, it was my larynx. And I did this because there was no room at the back with that very, very thick bone to make a back cut. So here we are making our anterograde posterior septectomy. We're removing this thin bone quite simply with the Freer elevator. At this stage, it was quite easy, but inferiorly, that bone got very, very thick. So we brought our drill back in to bring that down to the floor as best we could, so that at the later stages of this procedure, we were able to go back to a binarial approach using that cross-court technique type of pattern I showed you earlier. So here we're going to put that catheter back into the nasopharynx, and then we're going to take it out of the mouth. And I did this so that I could retract the palate inferiorly and away from the surgical area to avoid drilling it with the drill. Now here we're going to the contralateral side. We're looking for our open sphenoid. It was too small to get the 4 mm suction into, so we decided to raise our flap. And here, because of this, I decided to raise a laterally based flap as though I would for a nasal septal flap, and then swing it out laterally so that we would have something to cover that thick amount of bone at the very, very end. So we're going to raise this in the same way. This is our suction separator. And then we're going to use the suction dissector that's curved to the left to push that out to the side towards the sphenopalatine foramen. And there you can see the opening to the sphenoid already. Now it was too small to get our 1 mm kerrison into, so we decided to approach this from the bottom. And so we're going to continue to drill out the bottom of the sphenoid here. And now we can see that we're into the bottom of the sphenoid. We brought in our Choanal Atresia burr to make the rest of those moves, as this was a fairly safe place and we could use a cutting burr. But once we get this open, I start to treat it more like a sphenoid, more comfortable opening the sphenoid with a kerrison in my real life. And so that's what we did here, to really just open this space up widely and then to ensure that there were no thick bony edges. After we finished with this, we bring in our diamond burr just to drill back those corners. And so at this stage now, we've opened up the bottom of the sphenoid. We have a nice mucosally lined space at the top, our raw bone here that we're going to cover with our flap. And you can see an opening, a nice big opening into the oropharynx down below there without injuring our soft palate. So I guess I decided to look at this a little longer just to make sure that I didn't have any bleeding from the palatovaginal artery, but now it was time to get some hemostasis. This was an insulated suction Fraser, which we used because our suction monopolar was too large to get into the nose. And then here we're going to put our laterally based flap back down over that bone posteriorly. And then this is the inferiorly based flap from the right-hand side that we were going to use to line the floor of the nose. And then we just tap that into place. And then I usually support it with some Tisseal, occasionally some Surgicel if I need it, but no flap, no drug-eluting stent, and then the patient was brought to the recovery room. I brought this patient back electively at 1 month, assuming with all that bony drilling, I would be dealing with some neoosteogenesis and granulation tissue, and we cleaned that up for them. And then this was them at their 1 year follow-up with things fairly well opened. One little area here where we snipped open this scar. But since that time, this patient has now passed their overnight polysomnogram. They are currently capping for 24 hours a day, 7 days a week for over a year now. It's been actually hard to get them to move towards decannulation because of all the stuff they went through in the beginning of their life. But they will be coming in for decannulation in the next couple of weeks. And this is one of the greatest things I think we can do when we're in pediatric otolaryngology. Overall, I've had about 25 patients with bilateral choanal atresia with a median age of 21 days at the time of surgery, which should sound a little bit old to you. And that's because if you see in the range, one of these patients actually presented with bilateral choanal atresia at 16 years of life, with just having been a stuffy, congested kid their whole life, which I did not think was possible. I've had 3 revision cases, and one was in a healthy child. One was in the Treacher Collins patient that I mentioned to you that I brought back electively. And then one was a patient with charge. And although these numbers sound kind of good, what I have to admit to you is this patient with charge required 5 revisions in the first 2 years of their life. But subsequently, has not been back in the last year, so is doing quite well. When we look at our patient that we started with, this is our young baby with charge. This is his 2 year follow-up visit. You can see that there's a bit of scarring out laterally there, but the nose remains fairly patent. And although that scarring drives me nuts, and I want to take it down so badly, he's been doing quite well, and the family has informed me that we will not be going to the OR anytime soon. Although revisions were usually occurring within the first 18 months of life or after surgery, I tend to follow these patients and plan to follow them for life to ensure that they don't run into any trouble, particularly any trouble that I caused. So I think what I can say for sure is the preoperative workup in these patients is critical. This is a multidisciplinary condition that requires everybody at the table to ensure that these patients get the best care possible and make it through our operation. I think stenting has a role, but I do think that we need to be clear about what it is. And to believe that what we're doing is getting children through periods of airway obstruction from swelling rather than preventing stenosis. And I think that when we stent as a result, short courses are probably ideal. I think we want to cover the bone whenever we can to limit the amount of osteoneogenesis that can occur. And we want to avoid the circle, my friends, whenever we can to give our patients the best outcomes possible. I want to thank you very much and open the floor to questions and comments. And I do really want to hear from your experience because, as I said, only as a group can we achieve mastery in this condition.
Thank you so much. I love that. Before everyone starts putting questions, I'm going to ask a few questions. Your point about stenting, not stenting, is really nice. I remember when I was talking to one of the surgeons during my early cases, they said stenting is mainly for surgeons' mental satisfaction or a good sleep rather than something. So the role of stenting is questionable. There was one thing that regarding mitomycin, which was commonly used. I do want to ask, um, does mitomycin hamper ciliary dysfunction? That is also one of the reasons that we should avoid using it. Or
Yeah,
have you
actually, you know
heard?
what, Dr. Nate, I actually don't know. That's I'm gonna have to look that up. Is that true? Is that something that you've heard?
Yeah, that's what I heard. That's what they said that, you will create a nice big opening behind, but you'll cause ciliary dyskinesia, which is not something that you want.
Yeah, that's
Um,
interesting. I think my biggest concern is just like, does it stay there? And I think when we all get this, like we see this in subglottic stenosis, choanal
hmm,
atresia. These circles want to scar down, and drives us crazy. We feel so badly for the patients, and we get to this stage where we're like, let's just do anything. Let's just try anything. And like, we use it, and then sometimes it seems like it opens and it feels good because we got a win. But I think when people start to study it more consistently, the outcomes are a little bit less encouraging. And so again, I think that when you're at that stage when you just don't know what else to do, you could try something. But I probably would, especially if there's some concern for ciliary dysfunction, I think that's the last thing we need to do to these kids.
okay. I want to ask some surgical questions. Number one question is that um, what if you're going over there, the turbinates are really bulky? Do you like lateralized turbinate to create more space, or what would you advise to create more space for the instrument to pass on?
Yeah, I think I think am I still sharing? Sorry. I generally lateralize the turbinates. I know that Elamidil will commonly re- debride. Elamidil is one of the rhinologists in Boston Children's, will commonly debride the posterior edge of the turbinate. Um, but I truthfully have no compunction with removing inferior turbinates in young children. If that's what you need to do to get that kid extubated, I have no respect for the inferior turbinate.
Okay, there are a lot of questions. Let me cover those questions, then I'll come to my questions. Uh, so the first question that we are going to cover, you have answered, but I'm going to read out. After flaps repositioning, are the flaps secured using tissue glue or reinforced with balloon catheters? You
Yeah.
didn't mention about glues.
Yeah, I tend to put Tisseal down just to kind of tack it down for a little bit. I think that balloon catheters are not a bad idea. Some people will even use a finger caught. What they do is they cut the finger off of a sterile glove and a little mirror cell in there. This is a small space, remember, and we use it like that. If you and we'll put that in to hold things down. I think those are all reasonable things. Sanjay Parikh puts a nasal trumpet through the nose. I'm a little bit worried about anything that you have to put a shear force into because it takes so long to get those flaps down. You don't want to then roll it off with something, but
Hmm.
it works well for him, and so it's always something you could reasonably try.
Something similar that so Dr. Das is saying that we were using Foley's catheter for 7 days as patient can't afford stents. Okay, but now we have understood that there is hardly any rule of stent. So, yes, the
I
next
think if
question
you're
is,
using a Foley catheter to hold your flap down, that's something, and you're still keeping it in there for a shorter period of time. So I mean, maybe it's not long enough to start to cause irritation. That's okay. It is 7 days where they don't breathe so well through their nose and may not be able to get extubated. But there are certain times where we will occlude the nose too. Like if something, one of my partners will put a mirror cell into the nose. He doesn't put flaps down, but he puts a mirror cell in and impregnates it with Cyprodex every day um, and um, and keeps that in for 3 days. So, and of course, the kid can't get extubated during that time, but um, a couple extra days probably isn't the end of the world, but certainly not a bad idea.
okay. Um, Role of post-operative irrigation in these children. We use
Yeah.
budesonide residuals for in
Yeah.
saline.
We generally use Cyprodex, which is ciprofloxacin dexamethasone in the eardrop for otitis externa, um,
Mm,
and regular saline. So we do saline BID to TID and then Cyprodex drops to reduce the granulation tissue. The one thing you have to remember is dexamethasone is a relatively potent steroid, and so you want to make sure that you're watching the vitals because hypertension can occur. It's transient. And usually you're not doing anything too bad to their adrenal cortex, but we stop it after about 2 weeks.
Okay. So, yes, in revision cases, especially most of them are restenosis by soft tissue. So, would you go for balloon dilatation or other techniques? This was one of the papers which I read as a systematic review, and they did mention about that. So, what are your thoughts
Yeah.
on that using balloon dilatation?
Yeah, I think balloon is a nice option because you get a nice radial opening and it preserves some islands of mucosa that could potentially reconstitute those open areas. The only consideration is, the size of the patient and the balloon that you have and that kind of thing. Because the balloons are, like the Acclarent balloons are quite long, but it's definitely a possibility. We've only recently started doing the ballooning because it's so expensive for Canada, and so we historically just went in and trimmed like the raw edges. Um, but I now that I've used the balloons, I like it very much.
Okay. Um, Dr. Kumar and also Luca asking, do you have poster protocol? And if you can share something, if you have some
Oh,
uh,
sorry, post-operative.
protocol for managing what are the medications you use, or washes, or suctioning.
Yeah. Yeah, we generally limit deep suctioning in the nose until about a week to in case the flaps get suctioned off. Um, and we do BID Ciprodex 4 drops each nostril and BID saline drops, BID to T and TID saline drops and saline as needed for the nose. And it does get too much more complicated than that.
Dr. Dipal Joshi is asking, when do you plan surgery after birth? After how many days?
Yeah.
Any workup
I think
specific you need?
I don't have a strict number. I think what often drives us is how bad they're doing on the vent. That's what happened in this young baby. He didn't make, we wanted to get him to about the 3.5 kilo mark, um, because he was so close, and that, that's one of the risk factors for recurrence. But he started to start acting up like he might be getting a little vappy. And so we went ahead there. Sometimes we've gone earlier when they're, a good size, otherwise healthy. But I think the most important thing is that you don't go until the preoperative workup is complete, to make sure that this kid is going to get through that thing. You don't want to have a, you know, 2 day like a kid with two choana, but can't tolerate the surgery.
Um, in unilateral cases, do you operate earlier or postpone later? Now,
Can you
my
can you
old
say that
is
one more time?
in unilateral
Oh,
cases, do
yeah,
you operate immediately or do you wait for everything?
yeah,
Now, my experience, my oldest patient, I have unilateral choanal atresia, 62-year-old. They always thought they had polyps. They were using sprays, everything.
yeah,
And no one actually put camera in the nose. I don't know why.
yeah.
But yes, so for unilateral cases, do you operate there and there or you
Yeah,
wait?
I like to wait. I want to see them as soon as they get diagnosed. There's sort of a standing rule in the hospital that if there's a unilateral choanal atresia, they come and see Wolter. But then mo I try to coach them as long as I can because I find that once you hit two, surgery is nothing. Surgery is easy. You can stick your whole arm in there sometimes. And so, like you can really get a good outcome when you've got some bit more space. So we try and coach them, but we do see them fairly regularly to ensure that, they're not developing sleep apnea during that time, that they're not really struggling with feeds and growth early on. And what I found is, in the beginning, it takes a lot of coaching, a lot of hand holding. But then once you get 2 years and you're like, all right, let's go, the families are like, why? He's been doing fine for so long. And so it's only when like the boogers start to really bother them that they let you do the operation. So you can get most of these children by, but you have to watch them. Actually, just recently, a kid at around 18 months, so we were getting so close, and then the mom started to really struggle with breathing during sleep. And so we just took him and opened him up.
Okay. One more question from Dr. Balagopal Kurup. He is a very good pediatric ENT surgeon, I must say, from Mumbai. I know it's a different topic, but if you come across mid-nasal stenosis in mid-facial hypoplasia, how do you manage?
Oh, I hate mid-nasal stenosis. I am so Glad, and I would love to hear your experience on this. I have my general approach is is I look to see on the scan what's the issue. If I see that the turbinate has some space behind it, and I can just push that turbinate to the side, then no problem. Occasionally, we'll try to dilate it if we think that there's like it's just a big bulky bone and the septum is really thick. We'll try and dilate and crush those tissues. But I think that if somebody like you is asking me that question, you and I are talking about that craniofacial patient who's really, really so narrow. Their face isn't big enough. And in those patients, we have about a series now of 6 patients where we've actually resected the inferior turbinate, left a little mucosal flap on the side, and kept those patients from requiring a tracheostomy. And so I was pretty happy about those. It's small numbers, but that's my general approach to it. I really would love to hear yours because I think this is one of the hardest problems in pediatric nasal surgery.
Okay. Uh, just a simple question for you from if you want to say what are the landmarks to make that widest, biggest opening from one end to another end, what would you say? Superior,
For the in
inferior,
the back of the
lateral.
nose. So I think generally what I would do, my main goal is to get a really nice posterior septectomy. And the way that I was taught and the way that I try and do it is I use the middle turbinate to serve as my superior landmark,
Mm-hmm.
so I don't get into that olfactory mucosa up above. I don't get close to the skull base, and I come about a centimeter forwards and I find that that usually provides me with enough room. I try whenever possible to avoid taking down the mucosa on the lateral wall and drilling out to the side, except for cases like the one I showed you in the Treacher Collins child, where that was part of the big problem. But in that case, I had mucosa that I could swing back against it to prevent it from scarring in, because I think in some work on restenosis, one of the biggest problems is restenosis that's not membranous but bony from that lateral nasal wall when you go down onto it. When I know that I am going to drill out that bone, I take it right down to the descending palatine artery though. I want that bone to be really far back to buy myself some time for regrowth.
Okay, a practical question. The questions are, is they're raining. It's such a nice presentation. Usually, initial days endoscopy in the office is easy, but as the child grows up, doing a scopy becomes challenging. How do you
Yeah.
assess them then? And the
Yeah.
practice sets in.
Yeah, generally speaking, my path is I will scope them at will, like whenever I want, up till about 2, and then from around 2 to 7, it becomes a little bit of a, you know, gladiatorial ring when you try and scope them. So that during that period, I only scope them if I think that there's something that's actionable. So if they start to struggle, their nose starts to be constantly draining that very thick mucus that might be suggestive, those would be things that would make me decide to force a child at that age into an endoscopy. But after 2, I generally follow them clinically to see how they're doing.
Okay. Oh, they're saying they do cotton wool test and cold spatula test.
Oh, to look for
Right.
air movement. Yeah, that's a great movement. Yeah. Yeah, great move. Yeah. We usually teach
Right.
our parents to do the WISP test, like with the tissue, so that because oftentimes they start to worry, when they're home, oh, is it blocked or something like that. And then we get a call. So our nurses teach them to put the cotton wisp in front of their nostril to see it fluttering back and forth. And then they do it all the time. They have videos of it online and stuff like that. It's very funny. I'm glad you brought that up.
Great. Um, no more questions. Excellent session. I loved it. And I'm sure everyone did. And oh, one more question. Dr. Bala again. When do you intervene in restenosis?
Hmm. Yeah, I think I try and base it clinically on how they're doing. As much as I sometimes want to take some of that scar down, and I think nobody in rhinology can claim that they're not a perfectionist, and you see a bit of scar, and it just occupies a whole lobe of your brain. but I think I do it based on their symptoms. If they're having more congestion or they're snoring, sometimes if if they're really struggling through colds, those things would make me intervene. But otherwise, I try and give them time and just see how they're doing.
Okay. We have got Dr. Hassan from Turkey. Do you use image guidance navigation during the surgery?
That's a good question. Not routinely, but if it's something unusual like that Treacher Collins patient where I was drilling blindly for
Mhm.
through bone a little while, I do like to have it. But not otherwise it's not routine for me.
Okay. Dr. Dipali Joshi is asking, for membranous stenosis, what is the protocol? Do you just debride or you still do posterior septectomy?
For maintenance stenosis?
Membranous
Oh,
stenosis.
membranous. Yeah, I still will usually do a posterior septectomy. It's a lot quicker. All you have to do, you really just have to pop through. But I do think that change in our thinking about not making two circles like it looks like in a textbook patient, but or like a human with normal natural choana, having that three-dimensional space prevents you from getting that restenosis.
Okay, interesting. Uh, Dr. Kumar is saying choanal atresia is a very rewarding and life-saving surgery in such children with thankful parents. It's very nice to meet you. Meet them on their birthdays. Well, such a nice one. I know pediatric surgeries are quite rewarding in that way. Um, s- Dr. Zabir is saying that sometimes you start to dissect submucosal after atretic plate without penetrating through and through to nasopharynx. How do you make sure not? I'm trying to understand.
You dissect the mucosa after. Trying to play without penetrating through. I guess so. Perhaps sometimes you start to raise up that flap and you see into the nasopharynx, like we saw in that in our charge baby. I think if
Hmm.
you don't get through to the other side, that's okay. You will come through it with your bone. And now, if you're not sure, you can bring a camera, like a 120-degree scope through. I don't generally find that. I find that once I know the depth of the nasopharynx and I've looked at my preoperative imaging, I'm not too worried about height. So I think you can just start to get through that bone without whatever way you want. You saw in me in that picture, there was one case where I didn't. I tried to pick it off with a caudal. I drilled and then eventually got through that way. I don't know if that answered your question.
Yeah, great. Thank you so much once again. I know you have a busy day and you might have to go back to work. Um, it's a weekday and
Just clinic today now.
it's a weekday and we try to keep it on the evenings because we want to avoid the Saturday nights and Sundays. But
This is
at your
perfect.
place, it's still you're at the workplace, so thanks a lot.
Yeah.
Dr. Luca from Italy's last question. In case of restenosis, do you always repeat the CT to avoid radiations in children?
I try. It's a good point. It's something I struggle with, and it depends a little bit on if I did the surgery initially or not. But I think most of the time you can avoid that second scan. I think when some of my colleagues in Germany will use an MRI, I find it hard to interpret, to be honest. But if you sit down with your radiologist, I'm sure it wouldn't be so bad. But unless there's something unusual or the anatomy I don't know, or it's a patient that's come to me with a revision and the imaging is very old, I might do a CAT scan. But you're right. I think we want to try and avoid the second scan if possible.
Okay. Thank you so much again. And if there's any more questions, please write it to us. We can write it to Professor Walter, and we can answer. Um, Once again, thanks for your time. Thanks everyone for joining. Uh, and yes, that is his email. Oh, very kind of you.
Okay. Well, great. Thank you so much for having me. This was terrific, and I really appreciate all of your insights and questions. Like I said, we as a whole, and not by ourselves. Thank you so much.
Thank you so much. See you soon. Take care.
Thank you.